the palliative care team is going to be chatting with us today. So Dr. Adams, who's the division chief of palliative care, who joined us now, I don't know, what is it, maybe 6 months ago now?
Longer, June.
June, oh wow.
Yeah.
She came to us from Sinai and did your training there, right?
Correct.
And then has a pretty robust team now, and I'll let her introduce all of them.
Thank you so much, Dr. Fisher. This is Rachel Adams. I'm a internist and palliative care doctor. We put this talk together as a palliative care team. It's actually how we operate frequently, is in teamwork style, and we find, I guess I'm partially sharing that because in this moment where things are really hard, one of the things we keep coming back to is team. And so a few of us put our heads together and we came up with this talk in that same model. And so we're pretty proud of that. My other team members joining me on the call include social worker Cheryl Hughes, Dr. Michelle Milich, and nurse practitioner Beth Orell. Our talk is on COVID communication tips for the inpatient setting. And it is, there's probably some things that are relevant for other settings like outpatient or telemed, but because we're kind of in the inpatient setting right now where we're sort of first dealing with this is kind of where we're starting. We did a survey. Thank you to a number of you who gave us some responses. We'll be addressing some of the things we talked about in the survey, and then we're thinking after the talk, we'd love to send another survey out to find out how else we can help. We recognize that this is a moment of tremendous uncertainty for all of us, and that today, we're taking off a little bite of some of the things that we think are important in our training and to support the teams, but it's not everything. So for today, we're focused on communication, and then we'll send out some surveys to the residents and hospitalists to get a sense of how else we can help. Cheryl, do you want to add anything to that?
Just for a second, thanks, Rachel. I mean, as Rachel has said, this is a moment of uncertainty for all of us, and what we recognize is that generally when we are having these conversations with folks, we're not in distress or worry about our own health or our own family situation. And so it's easier to speak to these concerns of our patients. And right now, in this moment where we're worried about everything, it can be harder to have these conversations. And so just a general recommendation is just to take a few moments to ground yourself before you pick up the phone to call someone else, whether that means taking a few deep breaths or feeling your feet firmly on the ground beneath you. Just taking a few moments to center yourselves before you pick up the phone to contact somebody can really help from the point of view of just maintaining focus on this one call at this one time. So thanks, Rachel. I appreciate you letting me offer that suggestion.
So I'm just going to go to the next slide on our objectives. There are some things about thinking about communication. There are things that we're always trying to do in all settings. And then there are some things that are sort of unique to COVID. Some of the things I think real time we're all trying to catch up on and even learn are specifics to this disease and the quick course it can take for some people who get very sick very quickly. Because COVID has affected all ways of our life and even our hospital practice, we're now mostly, as Cheryl was mentioning, relying on the phone, which is different from a face-to-face conversation. So we're going to talk a little bit about effective phone conversations. And then these are some basics that we always find it helpful and grounding to go back to around outlining framework for goals of care discussions, things we think all patients benefit from. Some of the things that are unique for COVID patients, and then framework for some of the late goals of care discussions that are kind of springing up upon us sometimes within, 24 hours of a patient's diagnosis and admission. Finally, we have a number of different references throughout the talk, some for clinicians and some for patients that we think you may find helpful. I'm going to go to the next slide and pass off to Cheryl.
Thanks, Rachel. So in terms of tips for phone conversations, one of the biggies that jumped out to us last week when we started this was how hard it is to have these conversations when we don't have the visual cues from the people that we're talking to. Normally when we can see a family member crying or grabbing for a Kleenex, or even taking a deep sigh, we can pause our conversation and slow it down and acknowledge that emotion. So in these phone conversations, we just want to point out the importance of, making sure that we slow it down. And if that means that we need to just take a deep breath and listen for the emotion that we can't see, one of the things that I realized last week is that oftentimes when people are crying, they're crying silently on the other end of the phone. And we may not hear them until they take a deep breath in and we realize that that breath sounds ragged and that they may be crying. And it's those points in a conversation that really call for us as clinicians to say, to just say, I know that this is really hard to hear over the phone and we wish we didn't have to do it like this. But we understand that this is hard to hear. And then ask permission. Is it okay for me to continue with this information, or are there questions that I can answer now? So just having that in the back of your mind as you're making these calls, that sometimes we need to pay attention to what we can't see in order to be truly effective clinically over the phone. So some other considerations to think about are that lots of times people are also looking to us to see what our visual cues are for them. So it's another reason to kind of take this slow and ask people for whether or not they have questions or whether or not they've understood, or maybe asking them if they can repeat to us what they've heard or if they need further explanation. Remembering to describe all the care that we actually are providing. I think many of the questions that we'll get will be what cannot be done? Are there things that their family members or loved ones are not being offered? And I think it's really important to focus on what we are providing, and that any other comorbidities that might be a part of this patient's story and trajectory, we address separately from what the patient is experiencing in the world of COVID. Thanks, Rachel. So this is just an idea of ways to begin these conversations. So when starting a call, just noting up front that it's not an emergency, that helps people to ground themselves so that they're not going to, oh my God, what's happened to my mom? If we can say right off the hop, this is not an emergency, I'm just calling you with information, it helps people to get a framework for where we're coming from. And then identifying ourselves, whether it's, that you're a physician, or I'll say I'm a clinical social worker on the team, and that we're caring for this loved person, this loved one. And then describing what it is that we are doing. And it's great if we're able to say, I just want you to know, I just was able to talk to your mom, or I spoke with the nurse, or I've worked with a team that's taking care of your mom, so that they can have a visual that we can provide for them. Even though they're not able to be here, we can describe what we've seen. And that can be hugely beneficial for folks who in their minds are sending things to the worst place possible. And this last piece that I'm addressing in terms of addressing goals of care, it's important for us to think about the fact that no matter what stage of the game we're interacting with people, we want to talk to everybody about goals of care when they are being admitted, whether they're being admitted for COVID or not, but just remembering that this might be the only opportunity that we get to talk to someone about what kinds of care and treatment they do want to have. Remembering that lots of folks have had no experience in a hospital setting before, so they have no documented code status. many will feel more comfortable talking with a physician or a clinician about what kinds of choices they want to make, and also letting people know that, you know, if an illness were to get very, very serious very, very quickly, they may want to think about different choices than when they were just experiencing a chronic illness, something that likely would have a longer trajectory than this disease. So those are a few of the things to think about in terms of this particular conversation.
I think Beth is going to do our next slide.
So we wanted to address some hazards whenever you approach a goals of care conversation. It's important to keep in mind that you want to have a clear objective whenever you make a phone call or initiate a conversation with a patient. Keeping in mind that you have somewhat of an agenda of items that you want to discuss. Also important not to use too much medical lingo. We've found out that many people who have COVID and are seriously ill have never really either been in a hospital before, or their family members don't even really understand what intubation means. So we have to keep very, very basic in our language to describe that they're on a breathing tube and that they're attached to a ventilator. Again, as Cheryl said, we need to make sure that we attend to emotions, and slowing down and pausing can be an excellent way to attend to emotions during a phone conversation. It's important also to have in mind what recommendations we're going to be making about the plan of care before we move on to either choices or goals or values. Keep in mind what we will be recommending to the patient and or the family.
And this is Rachel. We're going to get back to this a little bit more later, but I think it's really important to talk to the attending, especially in the ICU, for example, about what those recommendations look like, because there are some situations where we really don't believe that somebody's going to benefit from some of what we're doing, and it's a slightly different scenario than things we faced before. We wanted to so after a few phone conversations last week with families that didn't know what a ventilator was, didn't necessarily know what it meant even to be on oxygen, I sort of was racking my brain for visuals that we could offer to people. There's a guy named Angelo Volandis. This is actually his wife that you see on the screen right now. Hold on one second. Ernest is texting me. I want to make sure. Oh, this is actually his wife, and he and Aretha, I think Davis, Dr. Davis, do these communication videos for a general audience that kind of describe a lot of advanced care planning things like intubation, resuscitation. So they've actually come out with a video now. It's about 8 minutes long, and it describes what COVID is, how it's spread, and these videos have been market tested. This woman has been through a tremendous, that you're seeing on the screen right now, she's been through a tremendous amount of training to learn how to speak, how quickly to speak. If you watch it, you'll know she speaks much, much more slowly than this New Yorker does. And that's what we found, that's what they found has been really essential for people to understand things. So I'm actually even thinking of using this video on Zoom calls with families if they have more questions, or if I'm getting the sense that they need a little bit more information about exactly what this care looks like since they can't see it. So one of the things that we're all dealing with is addressing prognostic uncertainty. These are just some ideas about how to manage situations where you might not be sure what the answer is. I personally face this type of issue every day. As a palliative care doctor, I see many patients who are outside the realm of the specialty that I see, that I was trained in, which is as an internist. So there's times when I don't know the answer to questions, but it's usually still an opportunity for me to understand their question better and offer to either find out what the meaning is behind what they're saying, or tell them I'm going to take the information and ask somebody else who can tell them I'll get back to them. So tell them you can't answer the question but would like to get more information. Tell me more about what type of information you are looking for. The other thing that fascinates me over time is that often the reason I think somebody is asking me a question is different from the reason that I think. So I'll have somebody say like, "Doc, tell me, am I gonna die?" And instead of answering that immediately, what I might say is, "Tell me more about why you're asking that question." And then you'll get very different answers. Sometimes it's that somebody wants to make it to a certain event, or there's usually something else that I wouldn't have realized, and that otherwise the question just seems obvious, like people don't want to die. And usually there's like a lot more layers to explore. And then, you know, especially when you're getting these questions you can't answer, people often benefit from just the opportunity to share their concerns. So you might be able to say like, "I'm not sure the answer to your question, but let me hear more." And that might itself be a very therapeutic intervention for a patient or family. I would also say, remember that "I don't know" can be an acceptable answer. One of the tricks with that is to say, "I wish I had a better answer to your question. We are still learning so much about how to care for people with this new virus." This is a question that came up on the survey and that I know people are talking about a lot around the hospital. What if someone asks me if we are rationing care? Cheryl, do you want to quickly comment on this?
Well, I do think it's important to acknowledge the fact that all of us are hearing from various media sources this concern about rationing resources. And I think just acknowledging the fact that I know all of us are hearing this, and it's got to be very, very scary for now, for you to hear that, but saying, you know, I want you to know that we are doing everything possible to take care of your loved one right now. So acknowledging that the fear is going to be there and that we're hearing the same kinds of stories that they're hearing, but also endorsing the fact that we are providing the maximum amount of care that we can in this particular circumstance. Without even going to it. I'm sorry, Rachel, go ahead.
No, that kind of gets back to something you mentioned earlier about emphasizing everything we are doing, which I think is a very grounding thing to say, also true.
Absolutely.
In terms of some of the more specific scenarios that you might face, there's actually a number of people who are doing quite a bit of work around this and around answering this really challenging question. And the link is up here. It's for vitaltalk.org. It's a communication guide, and there's just a picture of it here, and you can see some of the questions that they've kind of answered out. And this document is actually several pages long, but questions like, are you discriminating against her because she's old? You're treating us differently because of the color of our skin. It sounds like you are rationing. And the rationing one, what we are doing is trying to spread out our resources in the best way possible. This is a time where I wish we had more for every single person in this hospital. Thankfully, we're not at this point yet, but should we be, I think this is a really, really helpful document. And in terms of people worrying about what they may face and the anxiety of thinking what could those responses look like if you're somebody that needs more cognitive information, this is an option. And you can see on top, it's also available for download in multiple languages. In addition, the same group, and this is Tony Bach, who is behind with several other people, a lot of the Vital Talk stuff, they created a bunch of videos which are really helpful to watch. And there's a few different ones that are up. They're all under 5 minutes long. Some of them aren't even 5 minutes. But there's one that talks about proactive planning in the outpatient. This is sort of a scenario with a patient that has cancer and COVID, goals of care, withdrawing an event under a crisis surge. I would highly recommend that video for us in the inpatient setting. I think it's really helpful. And then facilitating a family phone goodbye, which has, and all of these things, again, have principles that this person and many others within the palliative field have used in a lot of different situations, but they're kind of tweaked a little bit for this particular setting. So a very helpful resource. Beth, I think we're turning over to you. Beth?
Sorry about that, everybody.
Welcome back.
This next set of the next set of slides is from Respecting Choices, and this is the company that came out of the La Crosse, Wisconsin Gunderson healthcare system, and they're also an excellent resource for advanced care planning. And I think it's really important, especially now, that we attend to these essential issues of identifying surrogate decision makers on admission, so that we're not caught unaware or in a crisis trying to scramble and figure out who we need to talk to. So Respecting Choices has a sort of a three-pronged approach to advanced care planning. They say that everyone, regardless of their health, should have either a medical power of attorney or a surrogate decision maker. And then when you're diagnosed with a chronic illness, you should have an advance directive, and there's lots of different forms of advance directives or living wills or 5 wishes, lots of different resources to write down your wishes. And then when you develop an advanced illness, then you should have a detailed discussion that is pertinent to what illness that person has or is diagnosed with, to talk about end-of-life preferences. Respecting Choices also came up with a proactive plan of care for COVID-19. This next slide just covers some of the order of the conversations. So there's an invitation and asking to start the conversation. There is a conversation surrounding identifying a surrogate. There is an exploration of prior conversations about planning for future healthcare decisions. There's an exploration of goals, values, and preferences. And there's a moment to pause and acknowledge our supportive care. So the invitation for patient to discuss some of the talking points that they have identified is just to name the uncertainty of this pandemic, and then to cover the trajectory of the illness. And I think at multiple points in this talk, we're touching on that point of how quickly sometimes people can get ill, and Michelle's going to cover later some of the patient populations that face a greater risk of serious illness with COVID. So telling people one thing that you can control in this very uncertain situation is identifying someone who can speak with you. Who would be the best person to help doctors make decisions if you are too sick to either participate or speak for yourself? Then explore prior conversations with the patient. Have you chosen a power of attorney, and what kind of conversations have you had with that person? Then further ask if they've completed any documentation about medical care and what you would want in challenging medical situations. If there's no power of attorney identified, then this should be addressed as part of the plan. I think the one thing that I want to note here is some people may be caught unaware, but some people may have had a very detailed discussion with their surrogate decision maker about what they would want if they were diagnosed with COVID. I know I have had that very discreet conversation with my husband, saying what I would and wouldn't want. So, yeah.
Sorry, go ahead.
No, go ahead, Rachel. Oh, you're going on to the next slide. Thanks.
Yeah, sorry. Did you want to say anything else?
Oh, thanks.
Okay, sorry. We're still getting used to this format. Exploring goals, values, and preferences. So this is just some of the ways that you can start to think about this. Again, I actually think that this is worth talking about with every person that you see in any setting, to be honest. We don't always have time for it. Now is the time when it's even more pertinent, but you know, I'm part of the MGUH healthcare team, and we are here to help patients talk about and plan for their care. We want to know about you, your values and preferences should you become ill. In a lot of cases, people won't have had that discussion. I've spoken with a lot of families where they just never talked about it before. But sometimes they still wind up sharing a story that tells us a lot about who the person is, and also about what their functional status is, and if nothing else, also really just helps us to connect with patients and families, which itself is huge. When I spoke with one family last week, they shared that the patient loves to go to thrift stores, and that they lost her once in Walmart, and they found her giving staff all of her recipes. Just like it humanizes somebody too. Sometimes you learn these things and it later becomes helpful in terms of attaching back to helping guide the family to come up with a plan that relates to who that person is and how they would wish to be cared for, even when they've never had that discussion. Regarding specifically goals, values, and preferences in the setting of COVID, here are some questions you could ask. What do you understand about COVID? What about the complications? What is most important for you to live well? What are you hoping for? And what worries do you have? This sort of goes back to, I think, another theme that we've been talking about, acknowledging all the supportive care that we're providing. Lead with what we are doing before we talk about the things that might not be possible. We want you to know that we are going to continue doing everything we are doing. We don't know if you are in this category of patients who are going to die from this disease. So sort of, again, naming some of the unknowns. I think with our next slide, we're going to turn over to Michelle.
Hello, everyone. I just want to echo, as we're having these difficult conversations, there's a lot of education and information that we can provide for the patients and their families. And I think one of the most important things is to give them, as you know, we're all inundated with news and media, and our phones are constantly indicating that there's more updates for news flashes throughout the day. And I think it's helpful to give information that is grounding and fact-based, and will help them to make potential decisions as well. In looking through some of the resources that are already out and published, the National Hospice and Palliative Care Organization has also set up some information for patients, including education about the virus itself, education and links to additional resources for information. And then importantly, they have a shared decision-making tool that is available. And we have a few slides with some of the questions that are asked on there. But the point of this particular tool is to highlight, we've been hearing a lot about who is at high risk. If you're a high-risk individual, the chances of having complications and morbidity and mortality is substantially increased. And it's helpful to give some idea about how much is that risk, how high is that risk. The largest risk that we can see is actually with age. So with increasing age, increases the risk. And you can see here on the slide, this is from the NHPCO website, indicating that approximately 15% of patients over the age of 80 will die from this disease. And that's important when we're thinking about giving our patients information and we hear perhaps a 1% mortality rate on the general population. Well, as we age and as we see on the next slide, there are additional pre-existing conditions that have a substantial increase in complications, including death rate. And those are, again, age, heart disease, chronic lung disease, diabetes, hypertension, and cancer. With the decision-making tool that is available online, it actually walks through determining your own level of risk, and then potential for what's my potential likelihood to survive. And then the second page of this decision-making tool actually stops and has a pause for a decision point. And the information there is based on my risk level. I want to be treated, and there are several options for hospitalization, for potential treatment at home. There are automatic clicks to address advanced directive based on state, and also clicks to potential for most or post. and 5 wishes. So that's a very comprehensive tool that folks can use at home and even be prepared before someone comes into the hospital. And then I just wanted to highlight a couple of unique situations with our patients with COVID. And some of the things that we're seeing is that our patients are oftentimes, once intubated for a prolonged time. So this is not our, community-acquired pneumonia with a few days on the ventilator and relatively quickly liberated to extubation. Many of these patients are having prolonged respiratory failure on the lines of 10 to 14 days. But there's also a small subset of patients that have been relatively unique to this particular virus. And those patients seem to be stabilizing or even slightly improving. Perhaps the ventilator settings are a little bit less. They're relatively hemodynamically stable. And then they experience this unexpected rapid decompensation. And our teams are referring to them as having a cytokine storm, and many of them have a myocardial involvement where there are profound complications and a rapid decompensation, where the teams are describing multiple pressors and death within hours. And just to keep that in mind, that is a potential, and we've seen that not necessarily in the advanced age population, but it can happen in the younger population and middle-aged population as well. So just recognizing that there could be something unique to these patients. And if you can go to the next slide, we think about how this clinical decompensation surprises us as medical providers. We can only imagine what the perspective is of the loved ones. And when they hear in the morning that things have stabilized out, and then by the end of the afternoon, we're talking multiple pressors and potentially even death. So helping them to prepare for this possibility and just planting that seed that this is something that may happen, I think is a very important piece. And I think if we're all having that same message and carrying that through, that could be helpful for families. On the next slide, when we talk about what is unique to this, to these patients with this rapid deterioration, I think one of the things that's important is to explain that should this happen, that CPR at the time of your death is not effective. And if appropriate, we can offer a recommendation. And I'm going to caveat this based on the information that we have already talked about throughout the slides and throughout the presentation here, with addressing goals and values first prior to making a recommendation. But this is the one special piece of this disease that, should this happen, one of the things that we might be considering is, referring to this catastrophic event and saying that, at this point, this is typically not something that we recommend because we know that the success is very low and it will not help to survive this illness. Again, I'm just going to echo my colleagues that we want to acknowledge those emotions and make space and availability for support, and to encourage and remind families that we will continue to take care of you and support and ensure comfort, and assure families and patients that this does not change our current care. And again, I'm not suggesting that every patient has this conversation of a do not resuscitate order. I'm just referring to that in this particular situation where there is a catastrophic decompensation, that we know that CPR is typically not effective, and many feel may not be warranted, and that information should probably be provided to the families and patients in advance, and just so they are aware of the potential catastrophic nature.
These are our wrap-up slides. Sorry, Michelle, did you want to add something?
No, it was Beth.
Beth?
Oh, are you going to cover these slides, Rachel?
No, go ahead, please.
Yes. So we've identified clinician resources for you. We've mentioned them along the way. Vital Talk, Respecting Choices. CAPC is another excellent resource, and I want to let you know, are updating their website daily with COVID-specific resources for you, and they actually kind of collate all the best of the best. And so they include the Vital Talk and Respecting Choices resources. And then for patients and families, this is a list of resources for them that they can access. And I think we've mentioned some of these along the way. To you, Rachel.
Thanks so much, Beth. So we're just going to summarize. We've discussed a lot of communication strategies around helping patients and families for managing with COVID. We are consulting on all the COVID positive patients in the ICU and trying to join, palliative team is doing this, we're trying to join rounds to try to help the teams facilitate, and if we can save the teams any time, we are trying to do that too. The palliative pharmacist, there's a few different interventions, and we can do this for floor patients as well. We're happy to be involved in any of the COVID patients, but one of the things our pharmacist is doing is to review meds and to see if we can bundle the medication schedules to make for the most efficient nursing work, just because each time people go in and out of the room, there's sort of PPE use and increased risk. So that's one of the things we're doing, is trying to help things move efficiently, but we're also trying to support the teams and save them time, sometimes around communication and support, and some of the work of finding out a little bit more about the patients and families when there is so much going on. I'd also like to remind everybody that we're available for all palliative patients ongoing. Yes, we're seeing the COVID patients. We're also available to see all the other patients. And we would really encourage you to consult us even more so in this time, because so much is going on and we can support your efforts and also be an extra kind of support service as well as a safety check for some of the patients and families. We have more ideas kind of in the works. In addition, one of the things that we will be having out to you in the not so distant future are guides that our pharmacist has been working on along with the Palliative Care Pharmacy Council that are sort of step-by-step recommendations around management of symptoms commonly associated with COVID. We have a few different action plans in place available for, right now where the volumes aren't too high versus medium high and also in surge. And we are committed to ensuring that there's palliative care services available to support all the patients, families, and our colleagues, all of you, as we all move through this as a team together. So I just want to thank everybody for participating in our talk. And I want to really thank also my co-presenters, Beth, Cheryl, Michelle, and our palliative team. Also out there on the floors today is Carolyn and Yurdanka and Tara as well, and Jen, who's just doing a tremendous work bundling all these things, among other things. We're really available to you, and we just wanted to say thank you to all of you. So I don't know if there are any questions. Ernest?
Yeah, thanks for talking today, guys. Some questions are coming in. One question just to answer quickly is, will the slides, links, and this video be available? And it will be. Hopefully the slides you can share with me. We can kind of bundle it all in one email out. I had one question before I get to some of the questions from the audience that, I think what I've seen around here is residents are getting more and more comfortable maybe with having goals of care discussions, at least starting some of them before COVID. Now I think one of the things that I've noticed that's different is that I feel compelled to do it in an age population with comorbidities that aren't that many. And I think starting that conversation with someone, for example, that's 40 years old that is otherwise healthy is a little bit difficult. I don't know if you have any strategies to how to initiate the conversation there.
It's a great question. It's one of, it sort of depends, but there are some young people who I would not traditionally think of as having serious comorbidities, but there are younger people that are in the ICU. I guess you might just start off with finding out what they know about COVID and moving into thinking about kind of talking about the range of possibilities and providing them the assurance that in all likelihood they will be fine, but also kind of supporting them and finding out what other additional needs and worries they have is just a starting point. Maybe Cheryl, do you want to add anything? Cheryl, if you're speaking, you're on mute, yeah.
I wanted to take myself off mute. I think, again, acknowledging at the outset that this is new territory for all of us. And so even though you, speaking to a 40-year-old patient, we may not have had this conversation a month ago, but it's important to have this conversation now because we're not really sure what to expect. And I think just using that caveat in general with the younger population can be helpful moving forward. Michelle?
Okay. One of the, oh, sorry, is there something more?
I was curious to know if Michelle had any thoughts about that, about talking to younger populations.
I think the principles also apply, you know, trying to get to know who the person is, what their values are, recognizing that there may be some aspects of meaning in terms of life and completion, in terms of their goals and legacy that may be different. And that's when I would really be thinking about pulling in additional supportive resources, having our social workers be a part of the conversations, having our chaplains get involved as well too. There can be quite a bit of stress that is around families having younger children, having work, having not had time or thoughts of doing advanced care planning. And I think looking at the patient holistically, just as you would, you know, a 90-year-old, I think is helpful, and just recognizing that we may all need to pull together to support these patients.
You know, in my limited experience, you know, 2 nights ago, I admitted this patient, and he was in his 30s. He actually looked pretty poorly, and you know, tried to start this conversation, and I feel like then the rest of the conversation we had was he was like looking past me. So I wonder if, you know, the conversation can't be just like traditionally someone does it and then it's settled, and it has to kind of be brought up maybe with every clinical change.
You know, Ernest, one of the things I experienced when I was in my previous role, all the emergency medicine residents rotated with me. The thing that they took away the most, first of all, they liked being able to roam around the hospital and see light because they were always in like a dark emergency room. But the other thing was that they realized that the goals conversations were more of a process than a one-off. And a lot of them were walking around with a lot of guilt that they weren't able to accomplish the DNR when they first met their patients in the ED in sort of a very stressed situation. I think that only applies more here. I think that this is so shocking that people suddenly have a serious illness with such an uncertain outcome that the only thing we can expect is that it's going to be a process. Some of the consults we've gotten already, granted we're starting in the ICU, but it's like from time to consult to intubation is a couple hours. And, you know, we don't have the time like we often do in medicine to, like, that's the thing about medicine is you usually have so much time to do so much. That's true in general for everything we've done. Like the emergency room is one thing, critical care is one thing, but in general medicine, usually there's time, and that's not as much happening now. So, you know, you're only going to get so far. I'm going to assume that your 45-year-old probably will want aggressive attempts at resuscitation, but, you know, maybe you're going to find out just a little bit more about that person, and maybe you're going to decide not to address code status in that first meeting, but to talk to that person just about who they are and how they're dealing with everything and what they're worried about.
And I do think letting folks know that we're talking to every patient about this so that they don't get the sense that we're singling them out because we have specific concerns, but letting them know that this is something we're talking to everybody about these days. So I just want you to be aware that this isn't about you specifically. We're talking to everybody like this, and that could help to reduce somebody's fear that maybe we know something they don't.
I like those ideas. I'll use them for sure next time. I wonder if one of the questions is about how you're handling family meetings. And I know you mentioned it's obviously different. It's something like this where you have to do it conferencing. But can you share any experience that you've already had doing a family meeting in this new format?
So this is Beth. I volunteered to answer this question. Well, actually, so we've used the phone and we've conference called people, but I also do understand, and people can clarify if I'm incorrect, but that we've been allowed to use Zoom and Skype in addition to telephone conversations for family meetings.
I believe, this is Rachel, I believe that's true, although I think even within our team, we're still trying to work out the kinks with that. Because I'm not sure, I guess I keep being confused still about PHI, but I think what rheumatology is doing, at least for their outpatient, which seems like it could work in inpatient as well, is to have an administrator reach out to the family, give them the Zoom, give that to us, and then basically schedule it almost like an outpatient thing. So we're gonna, I think, try that.
Yes, and so the take home from the family meeting that I did, it was not in response to COVID, but there are certainly challenges of making sure that everyone can hear. We had multiple phones out, and so you just need to really go slowly and do frequent check-ins to make sure that everybody's hearing what's happening, and then make sure to pause for questions.
And if I can just chime in, so I took part in several family meetings last week. What worked pretty well was having the clinicians who are actually on site be together in a room with either one or two phones, one phone conferencing in a family member and another phone conferencing in any staff members who might be off-site, and then verbally passing off that baton. So doing introductions first so that everybody hears everybody's voice, and then passing off the baton. So saying, Dr. Adams, I know that you had some discussions with this patient earlier. Are there things that you need to add? So that the folks who are on the phone get pulled into the conversation by the folks who are on site.
There's one, I agree with everything that Beth and Cheryl are saying. Sort of hand in hand with what Cheryl is saying, a pre-meet is really helpful. And pre-meeting, when I've worked with, this is actually comes to me from a critical care doc I worked with for years. I asked him, I told him at some point I was training somebody else to do something with ICU and palliative. And I said, what's the thing that you think is most important in terms of getting everybody up to speed? He said, absolutely do pre-meetings. Like make sure you as clinicians are all on the same page before you start. That's true on a normal day, and it's even more true on a telephone meeting. It could be really helpful to figure out both what you're saying, to assign roles, and you might have noticed we've even had to do that during this presentation.
Yeah, so Dr. Walton wants us to remember that we have kind of full use of any type of media right now just because of the crisis. But down the pipeline, we'll hopefully have the MedStar approved version of it to be able to deploy inpatient like they're doing in the outpatient world. And then I think, yeah, coordinating the group before having the meeting will also help iron out a lot of these logistics of just getting on the conference so that everyone's heard and their connections are working before you actually start to talk. All right, we don't have any more questions. If there's any other comments you guys want to leave us with, it'd be a good time. We have a few more minutes.
Well, we're going to send out a survey, probably SAFIT surveys to the hospitalists and the residents because we are available and ready to think with you around other discussions. You know, we can do case presentations. We can loop in some other folks who might have certain experiences. So and I know that there were also some questions around how to support patients and teams. We're trying to work with arts and humanities as well as our volunteers to think about some of those support items that can be done telephonically, as well as the volunteer services group. But then in terms of thinking about how we support other clinicians, we're really ready to get creative with you guys.